Hello and welcome once again to The Verdict. Mick Cornett with Kent Myers. We're glad you're with us. We're here every week meeting interesting people and dealing with topical issues. And today we are going to move into the healthcare field.
Yes, with a very special friend of The Verdict, Chris Howard, who's the Chief Executive Officer of SSM Healthcare of Oklahoma, will be joining us and talking about his organization and what they do. And I will point out that they are a sponsor of The Verdict, and we're very pleased about that. We're going to find out about, among other things, St. Anthony's Hospital, where I was born.
Chris Howard, today's guest on The Verdict. We'll be right back.
How do we create a better world of energy? The answer is obviously not foreign oil. Wind and solar need decades of development, and we've set the bar higher for the environment than coal can achieve. So the answer? American natural gas. It strengthens our economy, reduces pollution, and protects the environment. Learn more at chk.com. Chesapeake, America's champion of natural gas.
Wilsey, Meyer, Eatman, Tate. We're accountants. We do taxes, business valuations, estate planning, and consulting. And we're right here in Oklahoma, working with the owners of small and medium-sized businesses. Steve Wilsey and Stuart Meyer have the resources and the experience. Wilsey, Meyer, Eatman, Tate in Oklahoma City and Tulsa.
There's no waiting at the St. Anthony ER.
No waiting.
Announcing the end of ER waiting at St. Anthony Hospital. Go to saintsok.com and reserve your time online.
Why didn't we think of that?
And welcome back to the set of The Verdict. Mick Cornett with Kent Myers, and Kent's going to introduce today's guest.
We're really pleased today to welcome Chris Howard, the Regional President of SSM Healthcare of Oklahoma, to join us here on The Verdict for his first visit, and we sure hope not his last. Chris did his undergraduate work and 2 master's degrees from the University of Oklahoma. He has more than 20 years experience in healthcare administration. For the last 15 years, he's been with SSM, and he's going to tell us more about that. The last 5 years, he's been the regional president in Oklahoma for SSM. We're sure pleased you join us. Welcome.
It's a pleasure to be here.
For the viewers who may not know, can you describe SSM Healthcare of Oklahoma?
Absolutely. Simply put, we're a Catholic, not-for-profit healthcare system located here in central Oklahoma. Most people don't recognize the name SSM Healthcare of Oklahoma because we typically don't promote that. What we promote is our flagship hospital that I'm sure you're familiar with, St. Anthony Hospital. Kent, you were saying earlier you were born there, and many people have been. But also we have Bone and Joint Hospital. And truly between those 2 hospitals, we promote those names and brands, and we have over 200 years combined experience between the 2. Interesting story about St. Anthony. It was the first hospital provider here in Oklahoma, actually before Oklahoma was a state. Opened our doors in 1898, almost 10 years before statehood, and have been providing health care ever since that time, providing exceptional world-class services in oncology, surgical services, intensive care, behavioral medicine, and cardiovascular care. So it's a wonderful hospital, and it certainly is a gem down in the Midtown area. But also Bone and Joint Hospital is a second partner of ours, and we've owned it for the last 12, 15 years. It started almost 70 years ago here in Oklahoma City, and it is one of the top 10 orthopedic hospitals in the country with a world-class medical staff, and just does a great job providing services right down there in the Midtown area, right across the street from Bone and Joint. A lot of people don't know that, or from St. Anthony. A lot of people don't know that. Also in our family is a 70-physician medical group called the Saints Medical Group, with all sorts of specialties, a lot of primary care physicians covering all over the Oklahoma City metroplex and outlying communities. And we also have a partnership with another company through which we own part of Community Hospital in South Oklahoma City and Northwest Surgical Hospital in North Oklahoma City. So between those, our North Campus at St. Anthony North and our South Campus at St. Anthony South, that's our primary hospital complex of business. In addition, we have 15 affiliated hospitals around the state of Oklahoma in southern, north central, and western Oklahoma. And we do a lot of work sending our physicians out there, and I can tell you a little bit more about that later. But that's the SSM Healthcare of Oklahoma family. We're also a part of the SSM Healthcare family, which is our parent company, located in St. Louis, but we operate 15 acute care hospitals in 4 states, not only Oklahoma, but Wisconsin, Illinois, and Missouri. So we're a part of a larger corporation with 23,000 employees and about 140 years experience in those 4 states of providing health care.
It appears that medical providers are getting larger and
Absolutely.
developing more networks. Why is that necessary going forward?
Well, I think the short answer, Mayor, is that we will have a return to what was previously called managed care, something that not necessarily the most popular concept, but a lot of what we're going to experience in reform is going to require that providers organize together, because frankly, what do we need to do? We need to provide the most efficient care at the highest level of quality without wasting resources and without duplicating resources. And to do that, you're best left to come together with groups of providers so that you can organize your services and provide the best service to the community.
Well, when we talk about healthcare these days, you can't obviously stop without throwing out the word reform, because everybody's talking about all the changes that are going on in healthcare. So in trying to run a large organization like this, how do you handle reform from your end?
Well, first we try to figure out what it is. I think that's the easy answer. And if I could tell you that, I would no doubt be on the consulting tour.
Well, that healthcare bill is how many pages?
It's well, all told, I thought they said almost 4,000. I think it was 3,000 plus pages. It's a huge bill.
Yeah, it'll keep you up at night.
And I read somewhere once how many words it has. That's even more scary. But still, you can compartmentalize reform into a pretty basic concept. Our current healthcare system wasn't working, and most people don't know that, but in the United States, we spend 2 times per capita what more organized countries pay for healthcare services. And frankly, when you look at the healthcare outcomes that we have here in the United States, we're terrible. We're in the mid-30s in terms of rankings. Now, that's not to say that if you have an episode of care and you go to any Oklahoma City or Tulsa hospital or around the rural Oklahoma network that you won't receive exceptional care. You will. But the bottom line of it is that there's so much waste in the system and so many opportunities for improvement. We need to really address those. So the Patient Protection and Affordable Care Act, that's the name of the healthcare reform bill, tries to serve 2 goals. First is to provide protection for patients. Well, what do we mean by that? Primarily what we mean by that is we're trying to enhance wellness and clinical outcomes for patients. We're trying to assure patients that they'll receive a superior service, not receive an unnecessary infection, not have to be readmitted to a hospital, not a number of things. So that's a protection for the patient. But in the meantime, we have to expand the network and provide more care. And because we had so many Americans that were uninsured. Well, in doing that, you have to make healthcare more affordable. And there's so many facets of our healthcare system that are working against us making it an affordable system. So healthcare reform tries to address that. And simply put, if you look at the reason that healthcare reform, or the things that healthcare reform is going to address, it's primarily 4 things. It's 1, the fact that we're in an aging society. So we have more people needing to access healthcare services. 2, healthcare by and large is a very expensive proposition. Hospitals are expensive organizations to run. Physicians are highly trained individuals that are paid significant sums for good reason. Nurses, technicians, medical equipment, all very expensive. These are high-tech operations and organizations. And so you have a growing demand being provided in settings that's very expensive. So you have 2 things working against you. To compound that, you have a 3rd facet. You have our payment system. In the United States, our payment system is a fee-for-service payment system. That means that hospital providers, physician providers, et cetera, are paid per unit of service. So what do? We look for more units of service. Hospitals try to build more beds and fill more beds. Physicians try to build bigger offices and see more patients, and it's not because anybody's trying to do the wrong thing. Providing health care is supposed to be a good thing. But in the scheme of things, what we really need to do is move toward a segment of our population or a reform situation where we try to reduce utilization by improving the health of our community, not by trying to find ways to do more services or provide more services to the population as we grow older.
Preventive medicine.
Preventative care and wellness. That's exactly the direction that we're moving, Kent. And that's going to be even more important in the future because of the fourth facet, which is now we've added 32 million Americans to the rolls of the insured by 2014. So we're going to compound the problem. Aging demand or aging population, having a high demand for healthcare resources, expensive environment which healthcare is provided, a payer system that is counterintuitive to where we need to be going, and now we've added more to the problem. So that's what healthcare reform is trying to address. How well it addresses it, time will tell.
I just have to ask a really fundamental question, and forgive me for thinking about it. What does SSM stand for?
That's a great question. Nothing. That's an even better answer. Long story short, and I won't bore you with all the details, but SSM originally was the Sisters of St. Mary, and the order began when 4 sisters came from Germany to St. Louis, way back when. About 30 years or so later, the order broke in half for a lot of reasons, and a group of sisters went to Maryville, Missouri. They were the Franciscan Sisters of Mary. So those sisters were in Maryville, and the other sisters in St. Louis. Well, eventually those Franciscan sisters got on a train and came down to the Oklahoma Territory begging for money to take back to Maryville for their hospital. Local pastor caught them and said, "I'll give you money, but we have no hospital here. We want you to keep it right here and build a hospital." In 1898, that's where St. Anthony Hospital came from. In 1986, those 2 orders reunified, and I'm not saying they couldn't agree on a name. I'm sure they probably had a lot of ideas, but they decided to simply call themselves the Franciscan Sisters of Mary and adopt the name SSM Healthcare as kind of a standard between the two. So that's where the name came from.
There you go.
Fascinating.
Chris Howard with SSM Healthcare in Oklahoma. We're going to talk a lot more about healthcare and the changes and what it's like to operate a large healthcare system in central Oklahoma when we get back on The Verdict.
Most of the artwork that I produce is with colored pencil and watercolor. The subject matter that I use is, of course, Chickasaw. Most of my themes revolve around family and really that foundation that has been a part of Chickasaw life since ancient times. The Chickasaw Nation is a matriarchal society. You've got one lady, she's probably the oldest member of the family, that everybody goes to and that everybody reveres. That is something that every woman can look forward to in the Chickasaw Nation because they are extremely important in the family. Maybe one day I will be a matriarch. I think this is probably the secret to the success of our government, is that we still have maintained that idea that family is the most important thing and that we must minister to the family first, and then all other things will fall into place.
In Oklahoma, with the technology that's being developed every day, it would be difficult to get much better than it is now, but I anticipate that it will.
Technology's always going to improve. It's always going to get better, and as it does, these fields will give up more and more of their natural resources.
I think with technology and the way they're doing it, it'll be a good, clean, environmental place, and I'm blessed to be here.
The oil and gas industry runs deep in our history and gives us a sense that we have a really strong future ahead of us.
Welcome back to the set of The Verdict. Mick Cornett and Kent Myers. We're visiting with Chris Howard of SSM Healthcare, and we're talking about some of the challenges that you face. What about the state level? Is it different on the state level, or are most of the reforms coming from the federal level?
No, I don't think so, Mr. Mayor. I think that at the state level, 2 things come to mind immediately. First and foremost, I mentioned earlier that we're adding 32 million Americans to the rolls of the insured. It's only when you break that down and you translate it to what it means for smaller organizations and smaller things like states that it becomes paramount, the details that we're going to have to address. Of the 32 million Americans that are going to be insured in the reform bill by 2014, half will be Medicaid. In Oklahoma, if you translate that down, that's 350,000 new Medicaid recipients on our state's budget by 2014. Now, if you look at the state budget this last year and all that the state went through, and it's not just health care, but it's reaching health care the same as elsewhere, I don't know how we're going to afford to provide funding for 350,000 additional Oklahomans. What I do know was that a payer fee was passed, and I'm sure you all are familiar with the payer fee, but a payer fee was passed, which has been quite controversial and may well end up being repealed at the end of the day. I know Commissioner Holland has.
Yeah, Supreme Court's deciding it almost as we speak.
And if that goes away, that's $78 million that will come out of the Oklahoma Healthcare Authority, the state Medicaid budget, this coming year. So how are we going to handle that? Well, healthcare providers, hospital providers, have been advocating the exact same fee, only a provider fee, for the last several years. But we've had a hard time getting it passed or getting consideration because of its perception of a tax. My hope is that if a payor fee was passed, that the exact same concept for a provider fee will be successful in getting passed as well, because we need to help the state help itself everywhere we can. And what will be a shame is if that payer fee goes away and no provider fee is enacted, and the state's looking at a $78 million hole on an existing budget for providers that this last year took anywhere from 3.25% cuts to 18.25% cuts in the Medicare budget, in their Medicare reimbursement. I don't think that's a situation that we can sustain in the state. So we on the provider side have said, let us help ourselves. Let us go get that provider fee. Let us pass that, because here's an important facet of the provider fee. A provider fee is the exact same fee that a provider assesses on its revenue. That money is then used for the state to obtain federal supplemental funding, same as a payer fee would. But the difference is that that money then comes back to healthcare providers, and they can use that money to offset the fee that they paid in the first place. With a payer fee, that money doesn't come back to the payers. They simply pay the fee and they lose. But on a provider fee, if we end up going this direction, I think we could help ourselves tremendously by doing the exact same thing that we set out to do, but filling that $78 million void. It's going to be paramount, because providers in this community right now are, I wouldn't say rebelling, but I would say that they're limiting their practices to Medicaid and even Medicare patients, because the reimbursement is so minimal from those payers. And I don't want to see that problem become worse over the years, but if we don't do something, the state will face that hole to dig out from under, as well as the fact that disproportionate share payments are being reduced per the Patient Protection and Affordable Care Act. That's a significant reduction. Those are payments made to hospitals, supplemental payments for having taken care of a disproportionate share of lower income individuals. So over time, the next 4 years, those payments are also going to be withheld or reduced or eliminated. So hospitals are going to be looking at the reduction of those funds, in addition to potentially a reduction of additional Medicaid funding. I think people are scratching their heads trying to figure out how we make sense of all this.
Sounds complicated.
It is.
What would this mean to the typical consumer/patient in Oklahoma?
It's
just shortfall and all.
It's straightforward. First of all, for Medicaid recipients in this state, and we have many, and we'll have more, finding a physician. Many physicians, just simply due to the fact that much Medicaid reimbursement that we receive from the state won't even cover the direct cost of business, the actual cost of someone's time or the material that you use to take care of a patient, much less offset any indirect expenses such as paying for a business office or whatever else you have. So with that in mind, most providers who have, say, between 5, 10, or 15% of their practice as Medicaid right now, and many do, but they're not going to go to 15, 20, 30% because the population in the state grows. So I think the number one thing it's going to mean for the state from a consumer perspective is going to mean limited access to providers, especially primary care physicians. The shame of that is those are exactly the patients we need to be getting to primary care physicians so that we can take care of healthcare needs up front and reduce more expensive healthcare outcomes down the road.
Are more people likely to want to become a doctor after the reform? Is it going to be better for the profession of doctoring?
I'm not going to sit here and say that nobody will want to become a physician, because there's a whole generation of I call them kids now because many of them seem like kids going through medical school and into their residencies, but there's a whole generation of folks that are going through organized medical training that don't know any better, that won't know any better. It's my bigger concern is for the population, the age group of the physicians anywhere from 35 to 55 they're practicing right now. It's sort of like the mid-60s when Medicare and Medicaid were introduced in the first place. So much change. Some physicians elected to get out of medicine. Others eventually came in, but there was a lot of turmoil at that time. I think there's going to be the same level of turmoil right now, especially if the government continues along its line of, I wouldn't call them a tax, but I would just call it the reality of reimbursement reductions, Medicare reimbursement reductions to providers, because there's a dreaded 23% reimbursement reduction that's still looming out there for many providers that's been pushed back and pushed back and pushed back and pushed back. Simply put, you take that 23% away from a provider at the same time that many providers are taking 3 to 5 to 10% cuts in Medicaid reimbursement from our state. You have physicians that the only thing that's changed with them last year to this year, their income is less because they can't pay their people less. They can't tell their landlord that they're going to pay less for rent, and medical supplies certainly aren't getting cheaper. Same applies for hospitals. We can't reduce the expense of the core enterprise, and so that expense remains. But what will happen is people will consolidate, providers will probably come together and organize more in groups, hospitals will probably organize more together with the goal of trying to be as efficient as we can and reduce duplication of resources, because why have 2 business offices if you don't need them? Why have 2 sets of whatever if you don't need them? That's what I think we're going to see more of in the coming years.
Do you think we're headed down the road to a single payer system?
I don't believe so yet. And I don't believe so yet because I don't think that's what our society wants. I think our society enjoys, and I know I certainly do, competition. I think competition breeds improvement. What I worry about if we were to ever have one payer, that one payer being the government, is what would our society look like from a healthcare system standpoint? The government in charge of marketing itself, the government in charge of improving itself. I'm not saying the government couldn't do that. I'm just saying that I think that the St. Anthony's of the world, the SSM Healthcares, the Integrises, the Mercies, and others of the world have a far better opportunity to improve because we are constantly trying to improve services such as in-quick ER, rapid access to services, whatever we can do to make healthcare a more attractive proposition for the public.
Let's talk about quick ER real quickly because we don't have a lot of time. But I know it's an interesting concept, and your commercial alludes to it. Tell us about quick ER.
Simply put, what do people hate about going to the emergency room?
Waiting.
Well, yeah, absolutely waiting. I was going to say you hate going to the emergency room anyway. Nobody wants to go to an emergency room. But if you have to go in an emergency room, the one thing you hate is waiting. Now, this is for non-life-threatening conditions, obviously. Sure. If you have a life-threatening condition, you should go to the closest ER as soon as you can get there, just no delay. But if you're standing off your porch tonight and you fall and twist your ankle and you probably think I broke that ankle, and I know I need to go to the ER, but my gosh, I don't want to have to wait 2 or 3 or 4 hours because I know they're going to be taking care of life-threatening conditions. What do? Well, you log on to the Saints OK website, you look on the InQuick link down below, you click on it, you enter some basic information about you and what just happened to you. You pay a $25 fee. That fee goes to InQuick ER because their systems are connected to our information system so they can look at schedules, etc. And what you are told is when the next available appointment for what has happened for your condition in the midst of what's already going on at the hospital is. And let's say that it's a busy Saturday night and that's an hour and a half out, 2 hours out. Well, you click in, you receive an appointment time, and you stay home. And when it's time to go to your appointment, you drive down to the hospital, you walk in the front door to registration, you register, and your appointment, you're guaranteed to be seen within 15 minutes of that appointment, or your hospital-based portion of that ER visit is free.
Wow.
And the whole concept is to make healthcare easier for the consumer. I think that that's what we owe it to the community to do, and St. Anthony's had a long history of first, so this is just the latest for them.
Fascinating. Chris Howard, thank you very much for coming on The Verdict.
We're out of time.
Pleasure to be here.
Kent and I'll have a final word right after this.
Wiggins in to do the kicking. Here's the snap, and the kick is away. good life comes naturally to Tulsa, where nature's beauty is matched with an eye for aesthetics. A legacy of neighborhoods graced with lawns and landscaping and handsome homes. A place that seems to have patented an ideal lifestyle. Bank First is loyal to the quality of life Tulsa assures its citizens, to the priority placed on education, culture, and growth. Loyal to builders who transform raw land into residential charm. Developers who see opportunity and add vitality to Tulsa's economy. Bank First serves both enterprise and private lives that need a loyal partner. It's how we help nurture this city's very good life. Bank First. Loyal to Oklahoma. Loyal to you.
The Journal-Record is pleased to be a sponsor of The Verdict. The Journal-Record, since 1903, the best source of Oklahoma business news and legal information. And for almost 30 years, Oklahoma political, government, and business leaders have turned to the McCarville Report for accurate, reliable, inside information. Visit the McCarville Report online.
Welcome back to the set of The Verdict. Mick Cornett and Kent Myers. We're wrapping up the show with Chris Howard of SSM Healthcare.
Well, Chris was mighty generous to come talk to us about what's going on at SSM. A lot going on in the country and particularly in Oklahoma with them, and how they're going to deal with healthcare reform and what it means to all of us. It's an important topic.
Very intrigued with the technology involved with the emergency room and trying to get people in and out on a more efficient manner. I think that'll probably be successful in some cases.
Well, I think it sure shows some progressive thinking and willingness to do something different from the status quo, and for the benefit of the patient consumer. That's a really refreshing idea.
More information on our guest today can be found at ssmhc.com. That's ssmhc.com. You can find more information about Chris Howard and his company. And also you can go to our website and talk to us about a show or a guest that you'd like to see on the upcoming edition of The Verdict. That web address is theverdict.tv. For Kent Myers, I'm Mick Cornett. We'll see you next time right here on The Verdict.
The preceding program was produced exclusively for the Cox Channel.